All right, good afternoon, everyone. Thank you for joining us today for our South Texas Regional Family Medicine Grand Rounds. Next slide, please. Here's the activity code for today. I'll leave this up here for a little bit so you can all claim your CME credit. All right, next slide, please. This is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the Grand Rounds will address. Next slide, please. And here's a brief introduction from Dr. Shi.
Thank you, Catherine. So it's my pleasure to introduce Dr. Jonathan Nunez, which he preferred to be called JJ. He comes to us from Penn State Health. So he earned his medical degree from University of Connecticut, completed his residency at Yale New Haven in internal medicine, primary care track. Following this, he was an epidemic intelligence service officer, which I'm very curious about, at CDC, and completed infectious disease training at the hospital of the University of Pennsylvania. His journey led him to a career focused on HIV care, HIV prevention, LGBTQ plus care, and helping patients struggling with addiction. So Dr. Nunez's pronouns, the preferred pronouns are he and him, and currently he practices at Penn State Health, Pennsylvania Psychiatric Institute Advancement in Recovery, AIR program, and elder health. So he interacts with trainees on a regular basis, and Dr. Nunez was referred to us by Dr. Curtis Bone, so I'm looking forward to his presentation, hepatitis C updates for primary care. Thank you.
Good morning. So let me know if the slides aren't advancing or if there's some issue, mostly because I can't see the chat. So I have the pleasure of talking today. I describe myself as really being primary care and heart. So, I'm really under GIM. I do inpatient ID because, it's easier just to answer the question. I know there's a lot of wonderful work that you guys do for the discharge. But my career path actually was I was going to be a psychiatrist. And then a month before my letters went out, I decided to do medicine after a month of ICU. And all my letters actually were psych letters. And I feel like I do everything that I wanted to do in what I do now. So my goal is to really inspire the new learners because, to be honest, HIV management, HIV prevention, hepatitis C treatment should all go through you, mostly to feel empowered as we try to help patients. So for today, I'm going to review some of the learning objectives. I'm going to talk about evaluation and monitoring of patients with hepatitis C, identify and counsel factors that increase morbidity and mortality associated with chronic hep C, recognize clinical manifestations of chronic hepatitis C, and review evaluation and monitoring of patients with hepatitis C. So in the US, hepatitis C is still the leading cause of morbidity and mortality, costing the US healthcare system actually billions of dollars annually. It's the most common bloodborne infection, and 75% of cases are chronic, and the majority of hepatitis C infections in the US are going to be genotype 1. Even with the availability of many effective medications, the incidence of hepatitis C infection in the US has continued to increase in the past decade. So since I was a resident in 2011, finishing my last year, the amount of cases has actually doubled, and the age group has actually increased among 20 to 40 years of age. So from 2010 to 2019, the number of estimated annual acute hep C infections increased by 387%. And when we look into that, males tend to account for 60% of the cases, and the highest among 30 to 39 years of age. When we look at race and ethnicity, mostly white males comprise 65% of the cases. And when we think of the highest cases occurring, typical of the 5 states are New York, Ohio, Pennsylvania, Florida, and Indiana. And when we think of deaths attributed to hepatitis C, 72% of cases are going to occur in males, and total of hepatitis C related deaths are highest in white persons, but related death rate is highest among American Indian and Alaskan Native. So when we talk about injection substance use, it really accounts for about 60% of cases. So a crazy fact is, in patients who start injecting substances, in 2 years, about 20 to 30% will develop hepatitis C. And if they're still injecting within 5 years, about 50%. So when we're thinking about estimating hepatitis C prevalence, the figure on the right really shows how hard and the complexity towards it, because there's a lot of multiple factors that go in. New infections, spontaneous resolution, treatment, cure, it's hard to follow, and then reinfection. So this is kind of showing the number of acute hepatitis C infections overall, actually going back for a minute. This is just showing the amount of people with hepatitis C and really how it's changed within the age. Okay. So when we think of acute hepatitis infection, the highest among, like I mentioned before, it's going to be from 18 to 39 years of age. And the transmission is greatest among direct sharing of needles and syringes. But it can really occur to any part of the injection paraphernalia. So the water, the cooker, the cotton filter that's used. And it's still a risk in non-injection substance use. So snorting cocaine, methamphetamine use is also a risk factor. The risk of acquiring is plausible through the use of pipe. And the thought process is because it's occurring through burns that can be associated with the oral mucosa. There's also the sharing of straws or tubing that can cause erosion of the nasal membranes, leading to bleeding in the nasal passage. And then the other thing to not forget is there is risk factor through sexual exposure, so which can attribute to about 15% in cases. So in monogamous heterosexual couples, transmission tends to be less than 1% per year. But at my time when I was an EIS officer in CDC, so I was like investigating outbreaks, kind of like the movie Contagion. My character, I guess, would be Kate Winslet, except I don't die at the end, very luckily. So, we were seeing that there was higher rates of men who had sex with men. And this was usually the risk factor that was identified was anal receptive sex. So there's some thought process that there's easier transmission, especially with co-infection of other STIs and HIV, and then sometimes also recreational drug use during sex. So it's currently estimated that only 44% of people are still unaware of their diagnosis. So it's really a reminder of why confronting hepatitis C in primary care is really, really important. So for us, the most common genotype we'll see is 1. When you think about the rest of the world, there are different prevalences that we can see depending on where in your world we can see genotype 3 or 4. So when we think of the majority of patients who acquire hepatitis C, many do not spontaneously cure the virus. So about 85% of patients will develop chronic hepatitis C infection. And of note, those that do clear, typically a majority of them will resolve within the next 3 months. And the concern with chronic infection is really the development of liver fibrosis, and a subset of patients, nearly 20%, will develop cirrhosis, which is the leading indication for liver transplant in the US. And previous systemic reviews analyzing the natural history of Hep C infection estimated that the prevalence typically will occur within 20 years, although there's different studies that really look at varying changes because the study populations that were studied are very different. And then there's other differing risk factors that impact fibrosis progression between the different studies. Although once there's developed advanced fibrosis, the risk of progression is quite high, so approximately about 10% per year. And once complications of cirrhosis occur, hepatocellular carcinoma versus variceal bleeding, ascites, hepatic encephalopathy, spontaneous bacterial peritonitis, liver transplantation is the only effective therapy. And what's crazy is that hepatitis C accounts for approximately 1/3 of HCC cases. So how does HIV affect this or other co-infection with hepatitis B? So co-infection drives the risk of hepatitis C acquisition via sex and increases the risk of vertical transmission from mother to infant. And HIV accelerates the timeline in the development of hepatitis C liver-related deaths, including fibrosis, cirrhosis, HCC, and death. And what's interesting too is hepatitis C also affects patients living with HIV. It causes a reduced or slower CD4 count reconstitution, and it also causes increased rates of malignancy, so mostly in particular non-Hodgkin's lymphoma. And when combined with other hepatitis B infections, I'm so sorry, what was that? Patients with combined Hep B and Hep C leads to more severe liver disease and increased risk of HCC. Okay. So although hepatitis C infection primarily affects the liver, the other organ systems that can become involved, many result in various clinical complications. We can think about chiroglobulinemia, renal disease, dermatologic disorders, diabetes, lymphomas. Extrahepatic manifestations can have a major impact on morbidity, mortality, and medical costs. And some experts have estimated that approximately 40 to 70% of persons with hepatitis C will develop at least one extrahepatic manifestation at one point. And the existence of any extrahepatic condition really makes treatment urgent. So when we think about chiroglobulinemia, right? So what we're having is these blood proteins in the serum. They lead to end organ disease because there's like an immune-mediated mechanism. And these complexes will deposit on the capillary and arterioles and venal walls, and they'll lead to endothelial activation. So what can happen is you have like leukocytoclastic vasculitis. Among persons who develop chiroglobulinemia, the hepatitis C antigens can drive chronic stimulation of B-cell lymphocytes, which can lead to induced B-cell clonal expansion. So a lot of times can be associated with malignancy like non-Hodgkin's lymphoma. The most common manifestations we'll see is palpebral-purpura. So thinking about vasculitis, chronic leg ulcers, arthralgias, weakness, myalgias, peripheral neuropathy, as well as renal disease. And when we think of renal disease, it's the systemic immune response to hepatitis C mediated by chiroglobulins that cause the issue. You can see insulin resistance, so higher rates of developing type 2 diabetes. And then even looking at previous studies and observational studies, there's increased risk for cerebral vascular events and cardiovascular events, especially in co-infection with HIV. So as we think of the multiple organs affected, we think of the complications of portal hypertension, leading to ascites, hyposplenomegaly, thinking about preumbilical abdominal veins. We see esophageal varices. It can lead to SBO, so small bowel bacterial overgrowth, which can also complicate with chronic pancreatitis. We can see anemia. You have an irregular imbalance of sex hormone imbalance, so you can see increased estrogen to free testosterone, so pulmonary erythema and hyperestrogenemia. So you can see hypogonadism and gynecomastia. So other things to kind of think about too is like you can see nail changes, clubbing, Dupuytren's contractures as well. Now, I put this here because I always describe that ID loves these figures mostly so we look smarter than we are. But when I look at this, all I want you to really know is that hepatitis C is a flavivirus, and really the entry into the hepatocytes still super complex, still not fully understood. But after endocytosis, what you have is the viral envelope will fuse with the endosome membrane and uncoating will occurs. And then you have viral proteases, which are needed. These are NS3 and 4, important because medications will target that. And then you'll process to the polyprotein into various structural and non-structural viral proteins. And then you have the NS5B polymerase, which is required for replication. Again, another target for medications. And then you have the final step of viral assembly and release, which is NS5A protein, which is central row. And again, all these things I mentioned, targets for medications. So there's a really cool historical paper from the Nature Review in August of 2022 that looks at the major breakthroughs of hepatitis C research and cure in the last 50 years. And I remember as a third-year resident, my continuity clinic was embedded in a methadone clinic at Yale New Haven. And at that time, the only treatment that was really there was interferon and ribavirin. And if you can make it close to 48 weeks and you had sustained virologic recovery, SVR, it was like another birthday. You would celebrate like a birthday with the patient. And then everything changed since then as the treatment landscape for treatment-naive adults with chronic hepatitis C infection has rapidly changed in the last decade. So at the time, genotype 1 used to be the most difficult hepatitis C genotype to treat. But as of 2017, there's been multiple safe, convenient, highly effective, all oral regimens recommended for the treatment that did not require ribavirin. And I apologize, I tend to use the brand names mostly because I feel it's easier for providers to remember. But really when thinking of the options we're using, there's 5, which I listed the brand name next to the actual generic name as well. And really as primary care, there's really only 2 to really remember, Epclusa and Mavyret. So as we discussed antiviral treatment, the recommendation is for all patients to be offered treatment. The clinical objective is cure, and the marker of success is sustained virologic response. So really being undetectable after 12 weeks of completion of treatment. In contrast to non-specific treatment like interferon and ribavirin, the direct-acting antivirals interfere directly and specifically where certain viral proteins required for hepatitis C replication. And then given the issues with interferon-based regimens, I don't know how many of you guys have familiar with interferon, just a lot of side effects overall from like anemia, worsening depression. I think one of the big things is now having many options that are very short and very, very effective. And when we think about regimen selection, it really depends on whether the patient's undergoing initial therapy for chronic hepatitis C infection or has relapsed infection following prior antiviral treatment. So as we looked at today's therapy, let's review some simplified regimens, right? So again, Mavorite and Epclusa. So when regimens have repeatedly proven to be effective in treatment with naive patients without and with cirrhosis, regardless of genotype. And I think that's one of the reasons I really stress on the learners, Mavorite and Epclusa. So it was the Endurance 1, which was a phase 3 single-arm open-label trial evaluated the efficacy and safety. And what they were looking at is between 8 weeks versus 12 weeks of therapy. And they had about nearly 700 patients with genotype 1 without cirrhosis, and 62% were treatment naive. And among the 8-week arm, SVR12 was achieved in 99%, as compared to 12 weeks, which was like 99.7%. And typically, when looking at patients with co-infections, we see rates of treatment a little bit lower. In Expedition 2, it showed to be just as effective in treating hepatitis C and co-infection with HIV, nearly a 99% cure rate. So what's the data for Epclusa? So where a majority of the data came from was the Astral trials. So Astral 1 was a phase 3 trial that was randomized for both treatment naive and treatment experienced with hepatitis C. And they were looking at genotypes 1 through 6, and they received 12 weeks of treatment versus placebo. And there was nearly a 99% achieved SVR12. And Astral 5 showed nearly a 95% efficacy of achieving SVR12 in patients living with HIV. So super, super effective. So this is a nice table, which one of the addiction medicine fellows had made, which was really extrapolated from the hepatitis C guidelines, so we're not taking credit for it, which really reviews the medications, its use for which genotypes, and some caveats for who can be considered for what weeks overall. But again, I try to make it easy. So really, I know I'm stressing it again, Mavorite and Epclusa. And I promise you, I'm not making any money from their pharma dollars to kind of highly recommend them. Okay, so real world. So what do we do with treatment interruptions, right? So I think one of the big things to kind of focus overall is missing doses of DA treatment is really common. And the most common episode of non-adherence lasted 1 to 2 days, about 61%. And when you look at the treatment window, about 11% of episodes were greater than 7 days. And despite that, the episodes of common non-adherence, SVR was still achieved in nearly 90% of those, even with missed doses. Now, in previous studies, where we might see more treatment failure is in patients who might have complicated cirrhosis as well, or co-infection with HIV. In those patients, typically we may have to treat a little bit longer for them to actually have sustained SVR12. So in patients who are post-transplant or have decompensated cirrhosis, it should be managed with consultation with an expert. And patients with incomplete adherence should be asked about factors contributing to adherence or non-adherence. And in general, a treatment interruption is less than 7 days, unlikely to impact SVR12 based on the data from the Simplify study. So when we're looking at the last 7 days, we would just pick up and start up. Well, what if they miss greater than 8 days? So if they miss greater than 8 days, we'll restart the meds. And again, restarting takes precedence over obtaining an hepatitis C RNA. And if they're negative, we just complete the original course with some consideration. If they have genotype 3 or cirrhosis, we may extend another 4 weeks. If treatment interruptions occur after 28 days, I think overall to kind of think about overall. So if it's treatment interruptions occurring after 28 days of treatment, If it's less than 7 days, we just restart and complete. If it's between 8 to 20, we just obtain the hepatitis C RNA, and again, may extend the duration an additional 4 weeks. But if they missed, if there's interruptions after starting 28 days of therapy, and there's multiple missed consecutive doses of greater than 21, or the hepatitis C viral load is positive even around day 20, we may stop treatment and then start thinking about treating them for treatment experience. This part I just put in there because sometimes they may be co-managed with subspecialists, but this figure is really nice because it's very real world, actually. So our patients are going to miss doses overall. So it's kind of what to do. But even with missing doses, the overall SVR response is quite high. Okay. So what do we do in patients that have suspected or evidence of decompensated cirrhosis? So the clinical trial data really shows that there's vast improvement in clinical and biochemical indicators of liver disease, especially between baseline and post-treatment week of 12. Although the improvements may be insufficient to avoid liver-related deaths or need for transplantation, especially in patients with severe portal hypertension or MELD score greater than 20. Real-world data is comparing treatment response with response rates from medications demonstrate that patients with cirrhosis and hepatocellular carcinoma, they have a way lower SVR rates than just cirrhotic patients without HCC. So I would say if you're concerned for decompensated cirrhosis, usually even I will co-manage with hepatology, as they might just require closer follow-up or might be dealing with complications or need to be listed for transplant. So when we think about the goals of therapy, right, eliminate virus, always think of SVR12 has to be done. So remembering to mark the date that they actually started the medication and making sure to complete. When we're thinking about it, it's really to prevent and reduce liver fibrosis and delay cirrhosis. And then we're trying to prevent complications, right? So we're trying to prevent them from having to require liver transplantation or have extrahepatic manifestations of disease. And the treatment actually decreases all-cause mortality by 20%. So the recommended treatments are now very straightforward. We still do have some genotypic specific regimens recommended, Zepitir for genotypes 1 and 4, Harvoni for genotypes 1, 4, 5, and 6. But we're really trying to move now to where most patients can use one that's pan-genotopic regimens. So we're either thinking of Epclusa or Mavyret. And we generally reserve Voseffi for salvage therapy. So in people who did not respond to first-line treatment approaches, most patients will do well with one of these pan-genotypic regimens, which definitely simplifies clinical care. So again, think of me when treating HCV, so Mavyret and Epclusa. And one of the things we'll kind of take a look at that sometimes determines what med we will use also will be payer preference, drug-drug interactions, genotype still, and then sometimes cirrhosis status. So why think of this as in primary care? So why do I love being a primary care doctor more than an ID specialist? Because we really get to help patients that are in need. So as we see the treatment options have improved drastically, there's still a challenge of getting treatment. So nearly 3 million Americans estimated to be infected with hepatitis C. 50% have undergone anti-hepatitis C testing, the first step in the cascade of care. However, we can see in each stage of the disease the failure to progress to treatment, an achievable cure, leading to the decreased numbers of persons achieving hepatitis C cure. And when we look by insurance type, we can see how many patients never make it to treatment. So I practice in areas where there is no subspecialist in remote areas in California. I practice in areas where there are several subspecialists, and we all become very well experienced with telemedicine. So if we wait for the subspecialists to treat simple cases, patients won't receive care. So it's what I try to reinforce with the residents when also thinking about HIV pre-exposure prophylaxis, right? If we wait for the subspecialist, we just make more barriers and our patients won't actually receive the medication to prevent HIV. So waiting for the subspecialist for straight core cases will just bottleneck the system. So CDC estimates that more than 260,000 people should be treated every year to eliminate the disease as a national public health threat. And even though medications have been available since 2014, few people receive treatment within 1 year of diagnosis. So part of the problem, cost, the initial price tag can still be super expensive. Now, though that the cost has been reduced, the continued high cost remains a barrier for many. Other barriers include access to healthcare professionals or competing health priorities in primary care. Pre-authorization. So I would say that's still an issue sometimes for our patients where it is clearly they should be treated, but all the extra hoops that you have to do. And then also when we're working with patients with social determinants of health, if there's unstable housing, active substance use, limited transportation, stigma, unaffordable diagnostic tests. Okay, so how has screening changed over the years? When I was a resident, the CDC had changed to screening one-time screening for those with birth years cohorts between 1945 to 1965. The reason for the earlier data had suggested that individuals born between those years represented a huge amount of the total population of adults with chronic Hep C. And in the US, at the time, such individuals accounted for nearly 81% of the estimated population of chronic infected individuals. However, the incidence of HCV infection is changing, right? We talked about how it's affecting younger patient populations, why screening has been expanded. And screening should be offered more frequently in those with risk factors. However, screening those just with risk factors was very limited in previous studies when we looked at birth cohort screening. And it has suggested that only 45% of individuals with evidence of hepatitis C infection reported having a known exposure. So failure to identify infected individuals, again, is a bottleneck to linkage to care and successful treatment. So as I mentioned, the importance of screening in patient settings, again, it provides opportunities to link them to primary care. So on the left, I want to note that the majority of acute hepatitis C infections may be asymptomatic. So only 20% of patients will experience jaundice, nausea, abdominal pain, or flu-like symptoms. So the initial screening begins with antibody testing. And ideally, most places should have reflex hepatitis C RNA testing. Some don't. So I do have limited a part of that at Penn State. Any indeterminate or equivocal tests should be followed up with hepatitis C RNA testing. And when screening in severely immunocompromised or hemodialysis patients, there can be a higher false negative antibody testing than immunocompetent. So for patients with a very recent exposure, presenting with acute hepatitis, checking RNA is warranted as the hepatitis C antibody can still be negative. And I tend to repeat screening every 6 to 12 months, depending on risk. So thinking of ongoing injection substance use, patients who are on HIV PrEP, I'll screen once a year if they identify as MSM. If they're with a long-term partner with hepatitis C, the biggest gap I really encounter in our methadone program is patients are told that they're clear when in actuality they were reinfected or viral load was never really done to confirm their diagnosis. So as part of the pre-treatment assessment, I think one of the big things to kind of highlight is the complete medical history, medications, supplements, thinking about potential drug-drug interactions, hepatotoxic agents, comorbid conditions, prior treatment history and immunizations. After screening and confirming the diagnosis, obtaining an appropriate alcohol and substance use history is important. So, determining the presence of current and prior alcohol use is important since ongoing intake is going to, even in moderate amounts, so 50 grams or more, which a standard drink is approximately about 14 grams, may accelerate the progression of liver disease. So obtaining an accurate alcohol history can be important. I usually start with just a single item screening. It's brief, memorable, requires no scoring. So do you drink beer, wine, or other alcohol beverages? And then following that with how many times in the past year have you had 5 if a cis male or 4 if a cis female drinks per day? And that has a positive test, about 82% sensitive. And then usually I follow up with the audit C. So again, how often do you have drink containing alcohol? How many drinks contain alcohol do you have on a typical day when you are drinking? How often do you have 6 or more drinks on occasion? 4 or more is about 86% sensitivity versus 3 in cis females. And other options include the cage. I prefer the audit, but I think really talking about alcohol use and the risk for progression to fibrosis, especially more if there's concurrent hepatitis B and HIV. Then we kind of go into explore the injection substance use history, as it can be an important risk factor for acquisition. It allows opportunities to screen for HIV and hepatitis B, also opportunities for counseling on safe injection practices, offering treatments or referrals to harm reduction services or drug treatment programs. Ongoing use or opioid agonist therapy is not a contraindication for treatment for hepatitis C. I do review with patients the hierarchy of injection, recognizing using safer injection practices. Arms first, upper then lower are safest. Hands tend to be more delicate, likely bruised, can become damaged. circulation slower in the hand, so healing can take longer. Rotating injection sites, circulation in the legs could be poor, so really trying, there's more complication for developing clots, and really avoiding groin and neck. In my practice, and I'm not endorsing anyone, just my practice, if there's no injection sites available, we talk about safe syringe use, either prescription or buying syringes overall, and then using single use to really avoid the infections, because the number of use will increase the chance for introducing bacterial infections and abscesses. So another component to discuss when considering treatment is staging. So there's non-invasive tests of hepatic steatosis and fibrosis have been used for many clinical scenarios. There's two general categories, serologic panels of testing and imaging examination. So when evaluating patients for hepatic fibrosis, using non-invasive procedures or approaches or a combination. So there's serologic tests. A variety of serologic markers have been evaluated to predict the degree of fibrosis. The most studied panels are the AST to platelet ratio. There's the FibroTrust/FibroSure, or sometimes the FIB4. And studies have shown they have a good ability to differentiate within significant fibrosis, so F2 to F4, but compared to insignificant fibrosis of F0 and F1. And the panels may be able to monitor changes in fibrosis over time. Imaging tests are awesome. Elastography estimates liver applying mechanical waves and measuring propagation of speed. Again, good for distinguishing advanced fibrosis. The barrier is that most providers may not have that in the office, and it requires referring to GI. So it's another referral that might actually slow down the system for the patient. So, I think the advantages of biomarkers, they're minimally invasive, they're less expansive. You can do it where you're evaluating the blood work for the patient. It can be done in the office compared to sometimes scheduling a FibroScan if you do not have one in the office. So reviewing the non-invasive tests for fibrosis or screening, so you can check AST to platelet ratio index score, predicts severe fibrosis and cirrhosis, but not intermediate stages. The FibroSure, which looks at age, sex, haptoglobin, alpha-2 macroglobulin, GGT, and total bili, estimates fibrosis. FIB4, so ALT, AST, platelet, and age, good for confirming and excluding cirrhosis if the score is greater than 3.25. Or the FibroScan is good for detection. So either one is good. I usually use what I can get. So if I don't have to refer them to somewhere else, I will generally do the biomarker screening. If there's data where I just feel like it's not accurate, then I'll follow up with a FibroScan. So when we think about initial baseline labs, right, we really want to check hepatitis C RNA. We want to confirm the diagnosis. We want to check LFTs, coagulation, just to make sure there's no impact on the liver. Creatinine and renal function, important. CBC, mostly looking at platelet count to assess for the FIB4. Hemoglobin, because sometimes if I use ribavirin, it might suppress might make them anemic. Really screening for HIV, hepatitis A, and hepatitis B, and making sure that if they're not immune to vaccinate. So hepatitis C genotype. Now, there's some guidelines that would say we really don't need this to treat. I haven't had much success of getting approval for medications without at least getting a genotype. And I do think that if you're dealing with Epclusa, then you really need to know that they don't have, the treatment might change with genotype 3. And I'll talk about that a little bit later, but we still check a hepatitis C genotype. That's different from a viral load, so you won't get the two together. And if there's childbearing potential, we'll screen for pregnancy as well. So when to refer when you're thinking of decompensated cirrhosis? Mostly because we need to manage and assess for varices and manage the complications of ascites and if they might need large volume paracentesis. And they may need placement actually for liver transplant. What about immunizations? So thinking about immunizations, really vaccinating for Hep A, hepatitis B. I tend to use Heplisivib. I don't even know if I pronounce it right, but I love the 2-dose hepatitis B vaccine. It can be completed in a month. The efficacy and response was so much higher in patients living with HIV and or have dialysis. And then really thinking about the pneumococcal vaccine guidelines as well. And then also really consider for HIV PrEP. So I might just ask if anyone feels or wants to share in the chat, how many patients do you guys have treated for Hep C, and how comfortable are you with HIV PrEP? And just remember, I can't see the chat, so someone might have to feel brave and share.
So I answer myself. I said 0 for Hep C, somewhat comfortable with PrEP.
Awesome. So that makes me so happy. At least, I can understand the Hep C seems so overwhelming, but very happy to hear the hepatitis C. So like coming from areas where I practice that are urban and going to central PA, I will say there are definitely bottlenecks for prescribing HIV PrEP. So when we think about screening, notes to think about, this is just like a table highlighting what we discussed about. But when selecting an appropriate agent, there's a wonderful site from the University of Liverpool, which provides drug-drug interactions to avoid. And then remember, you need to get the SVR12. And this is where I slip up too, because what happens is the patients will complete the treatment, but they really need their SVR12 because we need to confirm that they're actually virologically cured. If there's risk factors, I'll continue to screen. I tell patients doesn't make you immune, really monitor social issues. If there's issues with substance use, really try to make sure they're in treatment. We'll talk about safe practices. And then remembering if there's cirrhosis, they'll need ultrasound every 6 months to evaluate for HCC. So when we think about some of the monitoring that we'll do, I think it really has become simplified. I think the hard part is usually that discussion with the patient and making sure you order all the blood work. And I think the other issue and barrier that generally I'll see is really the issues with the prior authorization. So in Pennsylvania, I think the easiest one for us to get approved is definitely co-infection. I would say mono-infection, I still deal with some issues, but overall, as long as it's well documented, it has been well covered. I don't know how it is necessarily in your area, but I would say really the treatment is to offer it to anyone that's really ready. So I'm going to take a moment and kind of break down into a case. So thinking about a case, so we have a 57-year-old cis female who has HIV, co-infected with Hep C and hepatitis B. She has pretty resistant virus, so she's on a particular interesting HIV regimen because she definitely developed resistance. She has chronic hepatitis C diagnosed in the 90s. She's treatment naive, and her only other past medical history is CKD and polysubstance use. So when we look at her exam, overall, no evidence of anything to suggest that there is any cirrhosis. Her current labs, platelets are 145. She's not. Hemoglobin is 10. She's undetectable with a CD4 of 324. Her hepatitis C viral load is quite high, and then genotype 1A. And then when we look at her hepatitis B, she's surface antigen positive with DNA of over 800. So what would you want to do first? So I'll leave it up to someone feeling brave on the chat. Do you want to start with the hepatitis C treatment? Do you want to start with the hepatitis B treatment? Do you want to start HCV and HBV treatment at the same time? And again, someone might just need to share as I can't see the chat.
Ellen said HBV.
Okay.
Elaine.
Perfect. So when we think about it, there can be HBV reactivation with Hep C treatment. So we see this a lot, same things when patients have chronic Hep B and they're on HIV regimens and they're taken off tenofovir. So the ALT and AST can come up in 4 to 8 weeks after treatment. And among 20 cases of reactivation, 13% had chronic hepatitis B, which led to 3 with decompensation. And usually what we'll see is the reactivation will occur after being on treatment for about 4 to 8 weeks. So, as we're thinking about treatment, we really want to think about treatment with both, because HCV will compete and inhibit hepatitis B replication, but hepatitis C cure may allow for hepatitis B reactivation. And it could be quite high. I think the 2 cases I remember as a fellow was seeing one where they were offered no Hep B treatment and they developed fulminant liver failure. And I had another patient that was very similar that was on a tenofovir-based regimen in ART and taken off tenofovir and actually developed fulminant liver failure. So I always am super cautious about making sure Hep B is covered. But the thought process is we probably would do both at the same time. Should we be worried about any medication side effects? What should we worry to start for hepatitis B suppression? Do you want to consider treating her hepatitis with a direct medication for Hep C? Do we want to consider liver fibrosis staging? Do we want to vaccinate hepatitis A? So a lot of steps to kind of think about overall as we go through. So let's start off with medication interactions. So really, there's not many medication interactions to really necessarily worry about, at least from statin standpoint. Even though there's some that we can safely use, I just tend to avoid altogether. So I'll hold the statin while in use. Same thing for proton pump inhibitors. I just tend to hold off on them if I can. And then when we think about the certain types of medications to really be careful of is anticonvulsants cannot use with concurrent medication for Hep C. And then some antiarrhythmics. So thinking about amiodarone for some. And then dose adjustments with warfarin and DOACs is something to kind of remember as well. So there's a nice, again, University of Liverpool offers a lot of great Hep B drug interactions to kind of necessarily avoid when we're using overall. Now, one thing to kind of think about is there are resistant viruses. And when we think about these viruses, the concurrent substitutions are designed as treatment emergent or treatment selected. And testing is most important in clinical practice when the results modify treatment. So duration or inclusion of ribavirin or other treatment options. And the resistance that we'll typically see is NS5A, and the detection of mutations in the gene is really associated with NS5A inhibitors. So anything that ends with severe, so velpatasvir, elbasvir, ledepasvir, all those will develop resistance. So when we think about it, I think one of the big things I tried to highlight overall, again, is think of me when treating HCV, and HCV has 3 letters. So like when we're thinking of Eclusa, it's the only one that we do sometimes need to check NS5A resistance testing. And this is mostly also thinking about treatment experience, but that's why I tend to favor Mavorite. Pan-genotopic, don't have to worry about resistance testing. And on top of that, the duration is only 8 weeks compared to 12. So when we think about liver fibrosis staging, it's really important as part of our evaluation and thinking about when to introduce medications to really decrease the hepatocellular carcinoma risk. So in this particular patient, we see that her reading on the FibroScan is 27. So when we think about that, overall scoring card for her, because she's co-infection, that means she really is in the area of having severe liver stiffness. When we look at the CVAPT thresholds, her number tends to be above S3. So when we're thinking about this particular case, we really should be offering treatment because she's showing evidence of F4 fibrosis and showing signs of cirrhosis. So what would be our next step, right? So we would start hepatitis C treatment, obtain a liver ultrasound for hepatitis C screening. We would discuss goals of care, and then overall refer for GI. This is where I would hold off. I feel like if the patient has no complications for decompensated disease, we can still treat, and the efficacy is about the same, actually. So when we think about hepatocellular carcinoma, it's the 5th most common malignancy, 2nd leading cause of death in patients with hepatitis C. Among HIV, that liver disease risk increases even by 25%, and the 5-year survival is nearly 20%. So when we're thinking about screening, it's in patients with cirrhosis. So every 6 months overall, or consider sometimes an F3 fibrosis. We'll do a liver ultrasound or MRI or CT, considering if there's consideration of HCC. And then you will still monitor even after treating, even though there might be some resolution of their evidence of cirrhosis. The survival among HIV patients with compensated cirrhosis, the mortality rate is quite high. So 4 times in HIV positive with cirrhosis versus patients without HIV. And when we think about important drug interactions, I always describe the ID fellows describe HIV medicine as boring now. And I'm like, what? I'm okay with that, because I remember when I was a student and resident, 4 wards with HIV AIDS. When I was a resident, by the time I ended, it was 2. By the time I interviewed for a job at Yale New Haven, consultation service, right? And that really shows you how much the medications have gotten way better. But when we think about Biktarvy, which I can talk about in a whole different talk about same-day starts and why everyone really is on Biktarvy, there's very few drug interactions. So even though there's an increase on Bictegravir, in all honesty, I would still necessarily use it. Where we get worried about is medications that are protease inhibitors, and they're on the old version of tenofovir, because the hepatitis C medications are also protease inhibitors, so it can raise the level of tenofovir and it can increase the chance for renal failure. So clinical case number 2. So we have a 37-year-old male with a history of opioid use disorder, admitted for endocarditis. He was started on Suboxone during hospitalization, transitioned to Sublocade, so injectable buprenorphine. So this tells you a little outdated. I probably would have done Brixadi, the newer version, but I'm sure Curtis can do an excellent talk about that, so I'm not going to talk too much about it. So went to inpatient rehab, transitional housing, had these initial labs. They're Hep B surface antibody positive, and they're Hep C RNA positive with a FIB4 of 2. So they have some fibrosis overall. So one question I have for you guys: do you want to wait 6 months of abstinence to make sure that before hepatitis C treatment? Do you want to wait 6 months and repeat the viral load to see that they clear? Do you want to refer to GI? Do you want to refer to ID? I'll tell you a hint: it's never going to be refer to ID. So if someone feels brave with sharing that. And a reminder, I can't see the chat, so if someone feels brave, I just need someone to really volunteer a voice.
Pick A.
Yeah. Wait for 6 months. So it's interesting because a lot of that has necessarily changed, actually. So, when they look at areas where there might be some minimal monitoring, the patients did really well, actually, with curing their hepatitis C, especially in co-infection. So, in these studies, they just ended up giving the full 12-week course of Eclusa. No labs were drawn. There was no genotype or on-treatment lab visits. They had remote contact visits for week 4 and week 22 for SVR. They got blood work, and the patients actually did really well. So, active substance use does not mean they cannot receive hepatitis C treatment. There's a lot of data from the HIV world, because it used to be a marker for not providing it. And one of the markers that's shown that they can is that, patients living with HIV, even with active substance use, if they're on antiretroviral therapy, a majority of them can sustain being undetectable. So it shows that medications can be good. I think the tools we'll try to provide them is harm reduction practices if they're still active use. And then thinking about, well, I'll save that for the next slide. But there's some cool stuff that came out in the last few years. So like, you're usually really thinking about novel ways to improve access to treatment. So one is treatment bioresidential options. So a lot of the programs, if they're going to be there, will start ordering the blood work and providing treatment as they're in inpatient rehab. And patients do really, really well with very few side effects, actually. When we think about other ways to increase Hep C treatment, it's not necessarily old news. It's Hep C treatment being offered in a methadone program. Actually, again, because we have the opportunity to make sure that they get their therapy and treatment. And then really the only decent thing of COVID-19 is probably telemedicine and really providing access. So, having opportunities to necessarily reach more areas in Pennsylvania, right? So like I always describe, being in Philly and practicing in Philly, it's still really hard to get to the doctor in Philly. I have patients from Northeast Philly in Kensington, which is where most of our substance use in Philly has struggled with. It takes about 2 hours to get to Penn, which is in Center City. So I would say, like, there's barriers in being in an urban area, and then being in a more central PA, which is more rural for us, even more difficult. So, I think the telemedicine option has really helped me kind of help transition patients to be cured. So what to do post-treatment? You want to continue to assess for comorbid conditions that affect the liver, really focusing on obesity and hepatitis, MAFLD. I always forget because they changed again. So I think it's metabolic induced liver disease. Don't hold me to that. But overall, just recognizing that, really talking about other comorbidities, avoiding substance use if we can, nicotine, alcohol, focusing on diet and trying to make sure that there's a diet that won't affect steatohepatitis, reviewing safe injection practices, and then periodic screening overall. Now, my final question to you guys. So when would you have thought to consider treatment of acute hepatitis C? Does someone feel brave to share? So let's say a patient came in, would you wait 6 months for them to clear?
I would say if the provider is comfortable as soon as possible.
Yeah, yeah. So I think there's a lot of things that necessarily have changed overall. So I think, when we think about it, hepatitis C infection, there's really no pre-exposure or post-exposure prophylaxis with the antiviral therapy, which is recommended. But the new data and the guidelines in the last few years have really suggested that because we know that they're not going to spontaneously resolve, it's very low, anywhere from 15 to 30%, probably less than 20%. We probably should use a test and treat strategy. And the really thought process for that is we're trying to decrease the viremia incidence and prevent new cases of hepatitis C. And then the other issue that comes a lot is I might have a patient for a few months to treat. So either if they're seeing us in the methadone program or we're doing inpatient consultations actually overall, and they're here to complete some treatment for intravenous antibiotics, which again, a whole nother talk for how to transition patients to oral antibiotics faster. I'm for it. But I would say that, really retaining them in care. So in some areas where we know there's a high area where patients may move around, if they're ready for treatment, we'll offer treatment, actually. So I think the biggest thing I try to predict is that at least there's stable housing or a way to reach patients and making sure we get that SVR 12. So I don't necessarily even require a follow-up visit. I prefer if we can, but I'll do a telehealth visit. I'll do it as long as we can get the blood work overall. And then making sure that you feel comfortable with dealing with the underlying reason for them developing hepatitis C. So making sure that, if it's through sex, really talking about safe protective sex practices, if there's active substance use, really referral to addiction medicine as well. And a kind of final thoughts is tools of the trade. So I just want to throw out some awesome stuff for you guys. For the residents, you do not need to be ID trained to do hepatitis C or HIV. There's a lot of cool academies where you can get certified for HIV. I recommend it. I try to get many of the family medicine residents that work with me to do it. Tools of the trade, the GW course is an online tutorial. They have one for Hep C. They have one for HIV PrEP. They have one for HIV. It's free and it's wonderful, and you get CME from it. So for the attendings, thinking about prescribing PrEP, you guys made my day because, I still see low rates of Hep prescribing, especially in patients that are the highest risk. So at least for me, where I practice, my patients describe it as the old white man drug, because it's true. When you look at the epidemiology of Hep C treatment, most of it is older Caucasian cis males. When we look at where the epidemic is right now, it's usually under the age of 30 in African-American cis male trans female. So it's not even hitting the target area. So feeling comfortable to do that. I'll throw a plug for one of my wonderful coworkers and friends here at Penn State, who's one of the hosts for Curbsiders. So Paul Williams, there's a lot of great Hep C ones that they've done actually overall. So I recommend it for the residents, and they're very witty. I always enjoy talking to Paul. And then another clinical support is the PCSS. It's a wonderful free online tutorials on stuff on feeling comfortable, not just for substance use. They're relaunching their medications for alcohol use disorder as well. So it's really practicing overall. You are the front line in primary care. We are the front line. So I think depending and always having subspecialists, it's just a barrier for patients actually to make it to them. So I think, if you treat that, they get engaged and they want to stay in care. So at that, I'll leave it up for questions in the last few minutes. Book recommendation I recommend that I'm reading right now, The Sum of Us, What Racism Costs Everyone, is phenomenal. And the most gift book I give everyone, if you like sci-fi, and really with a Chinese history twist, is the Paper Menagerie. I think I pronounced it right, but I'll leave it there. And then I'm going to stop sharing so I can see everyone's faces. Okay. So any questions? I know it's a lot.
Thank you, JJ. I have a quick question. I guess it didn't hit me until you mentioned about this reinfection.
Yeah.
So for patients with suspicion of reinfection, or how do we capture them? Or do we check their viral load on yearly basis? Do we do the genotype again?
Yeah, so sometimes I would just keep an eye on the viral load. And if the viral load becomes positive, then re-genotype. actually, because that sometimes can catch it. So a lot of times Curtis can know because like in Kensington, there was an outbreak of Hep C occurring, and we knew because the most common hepatitis genotype is 1, but everyone from this community had a genotype 3. So like I would know that the patient flipped. I'm like, they must have reinfected there. But I'll take a look at the viral load. And usually it's not forgetting to check at least yearly just to make sure that patient didn't have a return to use.
Thank you.
Does any of the residents have any questions, or I'm going to look at the chat.
Dr. Nguyen
Great.
has a question.
Just to clarify, so you would get the RNA first and then you would treat, but at what point would you get the genotype screening? At any point?
Yeah, perfect. So I usually grab it all together. So if I am screening, just screening, routine screening of the population, I'll start with hepatitis C antibody. And then if it pops up positive, then I grab all my labs, including the genotype, because the genotype will not include the viral load. So that there's always very confusing, actually. So like you're like, oh, I got it, and they're very hard to stick, and I feel so bad to send them back. So usually I'll check it all together. Although a lot of the guidelines have recommend probably don't need a genotype. I'm just saying real world. I've just noticed that a lot of times the insurance companies will not cover if I don't have a genotype in HIV testing that is pretty recent. So usually that's what I do, actually. And then really talking to patients about risk, really thinking about ways to decrease alcohol use as well, because the fibrosis rate will go up much higher, actually, overall.
Thank you for that.
I think in our system, if I remember correctly, we do viral load when it's positive, the reflex genotype.
Yes, most systems do. I'm not talking poorly. I love my health system. I don't have that. I don't even have that on HIV antibody testing, which isn't real world because it will flex. So it will give you if it's positive. I 100% agree. And it's the way it should be actually overall. And then the only other thing to remember is if you're screening, I know I didn't put this on the slides, but making sure to do STD testing actually as well. So we're seeing so much syphilis, actually, so much syphilis. So in my patient panel, especially my HIV prep, I've been doing a lot of doxy-pep. So I don't know how many of you have felt on that. Have you guys been doing doxy post-exposure prophylaxis to reduce chlamydia and syphilis? I'm curious what your thoughts are.
I have not ever heard about using doxy for syphilis prep.
Oh, it is awesome. So I will tell you again, and I'm not putting a plug in, but if you guys ever want to talk about it, I'm more than happy to touch base on another day about it. But I was going to say, so my job as an EIS officer would be I had to go investigate these outbreaks, and it was such a huge waste of time. I don't mean it that way. I mean it more that you spent so much time, you never find patient zero. And for me in ID, if there's neurosyphilis, complications, vision, overall pregnancy always makes me very nervous. So like congenital syphilis, right? The rates are at the highest that's been globally. I mean, there is a bicillin, intramuscular penicillin shortage, crazy, right? I'm dealing with no blood culture bottles in a hospital system. I have no intramuscular penicillin. I feel like soon I'll be prescribing leeches or cutting, right? So overall, very medieval times right now. But it was super effective. So San Francisco and Seattle, and I'll keep it brief. San Francisco, Seattle looked at cis male and trans female in MSM in and without HIV, and providing 2 doses of doxy. So it's now described as like the morning after pill for sex. So you take 2 doses of doxy within 24 hours, and it reduces chlamydia and syphilis by close to 80 to 85%. The public health department in San Francisco is like, we're doing it. I miss my time in San Francisco because they were amazing. We're doing it. And then they did it. And then they published their data a year and a half out later, reduced STI by 50%. Now, gonorrhea is resistant. Now, the question always comes to me, what about resistance? What about resistance? Well, the interesting part of it is that 2 things. We use tetracycline for acne all the time. So like in all honesty, I don't see an effect overall of the biome when I'm treating. But the two things to remember in the last minute, because I know I'm over. So the last two things is that if you're preventing cases, you're decreasing the burden of the disease in the area, you're actually exposing them to less antibiotic compared to if they're fully treated, fully infected. So that's one. And two, for NARES, for MRSA colonization, actually decreases. So like as they've been following it, patients who are colonized with MRSA have decolonized with MRSA with doxy. So, if anyone ever has questions or things, feel free to email me or text me. I'm more than happy to offer doxy pep or stuff overall, but I want to respect your time because it is 2:30.
Oh, thank you so much. This is so informative.
No worries. Thanks you. Have a
Thank
great day.
Bye-bye.